Hello, and welcome to today's webinar, The Pathologist's Role in Breast Cancer Treatment. I'm Dr. Barbara Malkus, Board President for Massachusetts Breast Cancer Coalition, and I'd like to thank you for joining us today. Massachusetts Breast Cancer Coalition is dedicated to preventing environmental causes of breast cancer through community education, research advocacy, and changes to public policy. I am pleased to welcome today's speaker, Dr. Michael Misialek. Dr. Misialek currently serves as Associate Chair of Pathology at Newton-Wellesley Hospital, Newton, Mass. He is the Medical Director of the Vernon Cancer Center, Chemistry Laboratory, and Point of Care Testing. He practices in all areas of pathology in a busy community hospital, holding an academic appointment at Tufts University School of Medicine. He regularly instructs medical students and pathology residents. Dr. Misialek also serves as MBCC's medical advisor. Dr. Misialek, welcome.
Thank you, Dr. Malkus, for the warm introduction. It's always a pleasure to speak to the MBC supporters and offer my perspectives on breast cancer as a pathologist. I'm going to do something a little bit different today. The past several talks I've given have been designed at trying to share some information about what different types of breast cancers look like, your pathology report, what's important in it, things that you should look out for. And I'm just going to do things a little bit differently and talk about a program here that we offer, and that's something new that's just gaining traction across the country at different institutions. It's the opportunity to meet with a pathologist, meet with somebody like myself. Why would you want to meet with a pathologist? This is a recent story that I came across, and I think it kind of embodies the concept of why you might want to meet with a pathologist. Some of you may know Candy O'Terry. She was she used to be a broadcaster on Boston radio for several years, an entertainer. She has a website now about stories that she tells from different pioneers in their fields, predominantly women. And she went through a very public sharing of her battle with breast cancer. She was diagnosed just at the end of last year, and it's on her website, posted on her website, exactly the struggles that she went through. And you can see right here that it says it was 9 o'clock on Wednesday evening back in November when I checked online for the results of my breast biopsy the day before. So that's somebody's out there looking for their pathology report. That's something that I put together. I've signed out, it's gone to the medical record. And for me, I always wonder about the patient on the other side of my microscope here, the patient on this slide. Every slide that I see here is a patient, a family, friends. When I make a diagnosis, there's a whole chain of dominoes that get activated. And this is one story that may be familiar to many of you out there, supporters of MBCC, who've been affected by breast cancer one way or another. It was too early to check, right? But I did anyway. And there they were. I took a deep breath and opened the report. Scanning down the screen, my eyes landed on the words invasive carcinoma. And she talked about her care team. She's got pictures of her oncologist, radiation oncologist. In fact, she had her radiation here at Newton-Wellesley Hospital, and she really praises the entire medical care team publicly on her website, her different oncologists, the surgeons, and really detailed her care. One thing that she didn't talk about, and probably she didn't know that the opportunity existed, but the pathologist is actually a part of that team too. We don't just write the report and move on to the next case. We're part of the care team, and this cartoon here really symbolizes well the different people that are taking care of patients. Primarily, we start with the patient primary care partnership, the patient and family members with their primary care. Now, for somebody entering the breast cancer diagnostic wheel here, they may interact with a radiologist after they've had a mammogram for some sort of abnormality. The pathologist will make a diagnosis, and the patient will then be referred to medical oncology, a radiation oncology, a surgeon. There's nurses, other trainees, other navigators through this system to help the patient navigate their treatment regimen, whatever that entails. There's many different types of treatment for breast cancer, and it all really depends on the pathology. Pathology starts the whole process of care for the patient. Once there's a diagnosis, then a treatment plan can be put in place. It begins the healing process as well. There's a number of other healthcare professionals that are involved with the team. So many patients may recognize a lot of these fields in their journey through an illness, not just breast cancer, but other illnesses. And let's not forget about the pathologists who are key players here. So yes, you can actually meet with a pathologist. You do have a pathologist, and you're welcome to come see them, at least here at Newton-Wellesley. The first thing I want to sort of talk about is what do pathologists do? We don't just look at slides here under the microscope. We manage the labs in hospitals or off-site standalone labs where blood testing is done. We oversee the testing, the accuracy of those processes to make sure providers get precise, accurate results of their tests. So anytime you have blood taken or a sample of something sent for culture, or even when you go to a dermatologist or your primary care doctor, they do a biopsy of a skin lesion, that comes to a pathologist. All the blood work comes to the lab. The pathologists are responsible for overseeing the quality testing of that and giving appropriate diagnoses. That's one aspect of what pathologists do. We also are often involved in research. As you can imagine, we come across a lot of different disease processes and have a large repertoire of cases that we can go back to if we wanted to do a study and look back at a particular disease to try and learn more about it. Pathologists are typically involved in most studies where new discoveries are made about cancers and other illnesses, simply because we have a lot of data here in pathology. Many pathologists teach as well. We teach the next generation of doctors who aren't just going into pathology, but are going into other specialties and what they need to know about pathologists. So pathologists wear a lot of different hats. I'll share a little bit about my background. I have a long time interest in advocacy for teaching the public about what pathologists do, where we fit into the care team, so that they can become more engaged, educated about their care, and know what types of questions to ask, and even to reach out to a pathologist if they have a question that one of their other doctors can't answer. The College of American Pathologists, the CAP, is our national credentialing organization that oversees testing of laboratory specimens and has a very strict credentialing process to make sure it's very high quality. They offer leadership training in this area, of which I partook several years ago. At that time I started writing. I started sharing some of my observations about pathologists, what we do, why you should know your pathologist. At the same time, here at Newton-Wellesley, we were just starting a program where we would offer patients the opportunity to meet with a pathologist. For instance, when a patient was newly diagnosed and they would come in to meet with their oncologist, their surgeon, radiation oncologist, nurse, the other members of the care team, they were given the opportunity to meet with the pathologist if they wanted to. And a small set of those patients take us up on the offer, and they do come over to meet with us. And that's what I'd like to talk about here. The rest of the program is what's that experience like? What do you need to know about it, so that if you're interested, you can go back and see if you can connect with a pathologist at your institution, and if you can participate in the same type of learning experience. This was an article I wrote several years ago on WBUR about the unseen pathologist, why you might want to meet yours. And I talked about this exact experience where a patient came and I reviewed their pathology slides with them, showed them, for instance, what normal breast looks like, what breast cancer looks like, and went through and answered their questions that they had about their pathology. All right, so let's jump into what the experience looks like. The first thing, sometimes I will often give patients a tour of the laboratory, not just sit down right at the microscope here and start looking at slides, but give them a little background of what happens before the slide is actually made. And this is an example of a breast biopsy, a stereotactic needle biopsy, where little slivers of tissue are targeted in radiology and biopsied, and we receive them. They're very fine needle-like threads of tissue here. We will sort them out, put them into what we call these cassettes, close those up. They get processed overnight in a machine that dehydrates the tissue, and then in the next morning we embed them in paraffin wax. This is just plain old wax that you could buy at your pharmacy, paraffin wax. And the purpose of that is now it offers a medium for which we can slice into that paraffin and place it onto a slide and then stain it and look at it. Otherwise, if we didn't have this medium, it would be really tough to try and align these tissue pieces and really get them onto the same plane of section. That little cassette here is placed into this instrument called a microtome, and we crank this by hand, and each turn of the wheel brings this cassette down and back up, and it will shave off a little section of paraffin wax, and within it is that tissue that was represented there. And you'll get this entire ribbon of tissue that sequentially goes down through the tissue and may give us slightly different perspectives on the tissue, where we can kind of three-dimensionally recreate in our head what is on the slide here in two dimensions. That ribbon of tissue there is caught onto a slide. We put it into a stainer here, and out comes stained slides, where now you can see what is familiar looking, in that there's tissue here that's stained with pigment that has varying shades of blues, purples, reds, pinks, to highlight different elements of the cells and the tissue that are important when we render a diagnosis. The experience that I offer here is that a patient can come in. This is a teaching microscope here, so I'll sit here at the chair and drive, quote, drive the slide, where I put the slide down. I can change the magnification on the objectives, and this can seat up to 5 other people looking through the same thing that I'm looking at. We also have it hooked up to a monitor here, so in case somebody doesn't want to look through the binocular, the eyepieces here, they can look up on the monitor and see it displayed as well. And what I usually do is start off with what's normal. What does normal breast tissue look like? And the normal breast is made up of small lobular units of breast ductal tissue that usually are supplied by a central duct, and there's these outpouchings of lobules and ducts around it. So it looks very circumscribed, meaning you could draw a line around this. It's very orderly. These are very orderly looking glands and ducts that are single layer, or actually two layers of cells here. What can happen, normal breast, it can start to proliferate, and that's really what cancer is. It's the uncontrolled proliferation of cells without, all cells need to proliferate, but it's the uncontrolled proliferation where that can't be shut off. So cells divide autonomously without turning off of the switch. And what can happen, the first thing that can happen is these cells begin to proliferate, divide, and they don't have anywhere to go but inside the lumen, and they can begin to fill up the duct like this. This was once a duct that was 2 cell layers thin, and now it's completely filled by very atypical looking cells that have some cell death here in the middle. We call that necrosis, and some calcifications. This is what radiologists look for in a mammogram, is calcifications, and they're very adept at identifying which calcifications are worrisome, which ones are more likely to be benign, whereas others warrant further workup, such as a biopsy, to make sure there isn't an associated cancer. And oftentimes this process here, it's called ductal carcinoma in situ, can cause calcifications. And this is the earliest form of cancer in the breast, where the tumor cells are completely confined to that duct. They have not broken outside of the duct wall and have not gained access to this connective tissue, the supporting tissue around the breast structure. And why is that important? Because out in here is where you have blood vessels, lymphatic vessels, and can gain access to spreading to other parts of the body. So a ductal carcinoma in situ is a lesion that is contained. It does not yet have the ability to spread, to metastasize, and should be cured by surgery and potentially radiation if margins are close. And we'll get into that and what that means. The next stage along the cancer timeline, if DCIS was left unchecked, it could then penetrate through that basement membrane, and those tumor cells, now you can see here, just begin infiltrating throughout this background connective tissue. Sometimes they'll form little glands. They're trying to recapitulate normal tissue. So some will form glands, more solid nests, others will stream in this sort of single file arrangement. This is called an invasive ductal carcinoma. There's 2 major types of breast cancers. There's a ductal carcinoma and a lobular carcinoma. And the basic difference between them is a ductal carcinoma is gland forming. It's trying to form glands. It's trying to recapitulate the normal breast. Now, if you remember from the normal breast, it's not only composed of ducts, but there's lobules too that bud out like grapes from those ducts. And if those cells begin to proliferate uncontrollably and turn cancerous, when those invade through the surrounding tissues here, they don't generally form nests or ducts, but instead spread in this single file, sort of single cells or linear strands of cells. And this is very characteristic for a lobular carcinoma. It's important to the extent that the appearance is different, but they're both treated or both considered an invasive breast cancer. and generally treated the same way. I find it's very important for patients to bring along their pathology report when they meet with a patient, meet with the pathologist, and to walk through that report. Sometimes there's words in there that patients don't understand, or that they've asked their other doctors to explain and may have gotten a response of not sure, maybe check with your pathologist. And who better to explain the pathology report than the pathologist? I will generally walk through the report and highlight what are important elements of that report that may confer some suggestion about the prognosis, the behavior of that tumor. Do we think it's a slow-growing tumor? Is it a fast-growing tumor, or what we call the grade of differentiation? Is it something that's well-differentiated, moderate, or poorly differentiated? Ask the patient if they have any specific questions. I've noticed in the patients that we've seen here, they generally share a common personality trait, I guess, and they often have some science background or medical background, and they often come with a notebook with a bunch of questions, and may even bring a family member who has questions as well. But it seems as though meeting a pathologist appeals to a number of people, but particularly to those who may have some science or medical background, even mathematics. They are interested in knowing the fine details about their pathology. And I am a strong proponent that the more the patient knows, the more engaged they are, the smarter, the more informed that they become, and can participate much more actively in shared decision making with their other care team members, such as their oncologist and surgeon, radiation oncologist, when they have discussions about treatment. So I'll show a few of what I consider as examples of prognostic elements, meaning what are really important things to look for in the pathology report, and something that I typically show most patients when they come here to meet with us. And one of the big things is estrogen receptor expression, that's abbreviated ER. And every breast cancer diagnosis should have ER, PR, and HER2. Those are reflex tests that we order for any invasive cancer, and that's one of the basic drivers of what type of therapy may be offered. Is there a role for endocrine-directed therapy, aromatase inhibitors, and such, or, for instance, HER2-directed therapies? And I like to show patients what this means, ER expression, instead of just reading it on a report. You can recall that when I showed you the first images of breast cancer, those stains were what we call H&E, hematoxylin and niacin. They're stains that characterize and bring out the components of cells that stain with blues, pinks, purples, reds. They're simply dyes. We can take away the dye and substitute an antibody. And we have a lot of antibodies at our disposal that we can characterize cells with, and one of them is estrogen. Now this is localized in the nucleus of the cell, so when this antibody is applied to the tissue and it's developed, if the tumor is expressing estrogen, you'll see brown here. It means that there's estrogen receptor expression within the nucleus of that tumor cell. And generally, estrogen receptor expressing tumors offer more avenues of therapy. It opens up what I just talked about, the ability to use aromatase inhibitors, other endocrine type agents. We heard an excellent talk earlier this year in the Margot Goldman Memorial Lecture about ER expression and some of the newest therapies that are being studied about that. And that's what estrogen receptor positivity looks like. We do check for progesterone receptor expression as well. It's abbreviated PR, and this is exactly the same concept. It's localized in the nucleus, so positive staining or the presence of progesterone is going to be highlighted here by brown staining nuclei. And it often goes along with estrogen receptor positivity. It's not as strong of a prognostic marker. The oncologists generally rely more on ER, but nonetheless, it's something that we stain for. We report it. The final biomarker is HER2, and just briefly, what HER2 is it's a membrane protein, so it's in the surface of the cell. Remember, the nucleus here, the brain of the cell, is what we were looking at before with estrogen and progesterone staining, but HER2 is actually a transmembrane protein that facilitates signal transduction from the outside of the cell to the inside. And some of those transmitting molecules may be growth agents that will turn a cell on or turn a cell off. And activation of HER2 generally leads to cell proliferation, meaning cell division. The cells multiply, divide, they may migrate, they can often develop the ability to invade and impact the survival of the cell. So this is really a key pathway, a key mechanism that we have identified and have specific agents targeted against this transduction mechanism to shut it down, so to speak. And you've heard of Herceptin. There are many other agents on the market and coming to market as well that take advantage of when a cell is a HER2 expressor, meaning we score these as 1+, 2+, 3+, and 0. This is an example of strong HER2 expression, a 3+, and recall that the HER2 molecule is in the cell membrane, it's in the cell surface, so this antibody here naturally would stain on the cell surface. It's outlining the cells in contrast to ER and PR, which are localized to the nucleus. And this opens up another arm of potential therapy for a patient that's important in the report. Another important concept is what we call lymphovascular invasion. That's abbreviated LVI. And tumors, when they begin, and often during their evolution, a subclone, a subset of those cells may develop a mutation where they can then proliferate and invade into the blood vessels. And once they have access to the blood vessels, this is akin to a highway through the body. Blood vessels meaning blood or lymphatic system. They can circulate to other parts of the body. For breast cancer, one of the most important and often first areas of circulation too would be the lymph nodes in the axilla, in the armpits. And we may have a biopsy of a lymph node that a patient may have had that would want to review that, and I can show them that. This is what invasion looks like under the microscope. Here's a tumor cluster, and it's inside of this vessel here. This is a what we call an endothelial lined space, meaning it's a vessel. It's probably a lymphatic vessel, just because there's no thick wall here. Here are blood vessels. You can see there's blood cells in there, but they have a thicker wall. Usually lymphatics travel along with blood vessels, and this is something we're always looking for. Pathologists are always hyperacute to looking for LVI, and this would be something that we note. And again, that's an important prognostic factor that's going to be taken into account during a patient's treatment formulation of their plan. Is LVI present? Is it not? If it's present, is it extensive? Are there a lot of foci or just a single foci? And that may be important for a patient to see and understand what's focal look like versus extensive LVI, and perhaps that will help them in their decision process when they're faced with a choice with their other doctors of what type of therapy. When something's being recommended, they'll have a better understanding of why that therapy is being recommended. Margins. Here's another very common question I'll get asked about pathology reports. Now, margins really only come into play after somebody's gone to surgery. The first step in the diagnosis of breast cancer is the needle core biopsy, which I showed at the beginning of the talk. If that turns out to be a cancer, then usually there will be surgery offered, and that could be a lumpectomy, in other words, a breast conserving option, or could be mastectomy. When we get those specimens in the lab, they're larger. Here's a sample of a lumpectomy. It's a lump of breast tissue, and breast tissue is mostly fatty, so a lot of this is just adipose tissue, and the tumor and the glands from which it arises are inside of here. When we get these, they're typically oriented, meaning there's a suture that a surgeon has put on, because otherwise we wouldn't know what's up, down, forward, back, right, left. Knowing the orientation, then we will apply ink. And these inks all have a specific meaning. For instance, red is superior, there's medial, lateral, posterior, inferior, and there's a color on the back too. So we have 6 different faces that we ink, and then we will cut this, put it onto the slide, and the whole point of inking is now that we can tell where the surgeon cut, because we'll see that ink and we'll be able to measure tumor if it's present and how far it comes to the ink. Is it close to the ink? Is it at the ink? Or is it a safe enough buffer away from the ink that a re-excision might not be necessary? And the whole purpose here of inking is to make sure that the whole tumor has been excised. And if not, where are those, quote, positive margins? And what does a positive margin look like? People may read their reports and see these measurements in millimeters and really don't have a great understanding of what millimeters look like for breast cancer. And seeing this under the microscope, my personal experience is that it's become very enlightening for patients to actually see what their tumor looks like. Here's some DCIS, but this is all invasive cancer. And I'll actually measure and report this out in a report that the margin's negative and the invasive carcinoma comes to within 2 millimeters or whatever of the margin. The DCIS, we can quantitate and report the margin status on that as well. And that goes into a whole different discussion. And it brings up the concept of when you might want to meet with your pathologist. You could meet after the diagnosis of breast cancer to see just what it is, the cancer, what it looks like. But somebody might opt to visit the pathologist after they've had surgery and want to know more about their margins, because there may be discussions going on with the care team about radiation or going back for close margins or positive margins. And I think having an understanding of what that looks like, the quantitation of the amount of tumor that's present in relation to the margins is important for a patient to understand, so that you can have a really educated conversation with the other members of the care team and participate in true shared decision making about what's best for your particular care. every cancer is different. No two cancers are alike. Even cancers that look the same under the microscope may behave differently. And we have different tests to try and predict how they may behave. And some of those get reported in our pathology report, and those may actually be topics that come up during conversations as well about what more might be done to study the tumor further. I mentioned we had been doing this consultation program for several years. Back in 2019, one of my colleagues, Elijah Joseph, she's a pathologist at Lowell General Hospital, she was also putting together a program for patients to meet with their pathologists. And we collected our data and we shared our data about the experience of this program. This was one of the quotes that one of the patients made to Dr. Joseph was, "Please help me see the dragon I am slaying." And we go back here. To our knowledge, this study is the first report of direct patient pathologist consultation. Early data suggests the program may provide effective patient-specific education. High response rate and favorable assessment of the program suggests that it may be a valuable resource for some patients. So we reported the first study here back in 2019. Since then, there have been more groups that have expressed interest and actually reached out to us and the other authors on that first paper about our experience in setting up a program, how they might do something similar. So interest is definitely blossoming, it's spreading. It's still a fairly new concept to meet with a pathologist, and if you're interested in meeting with a pathologist, you should probably see your specific institution, reach out to your doctor for more information about whether that's available at your hospital or not. I'll share some of the other studies that have been written since then. Some of them are very similar authors here. This one was back in just a few years ago, 2021, about looking at multiple sites. This is a group out at Duke, also the Lowell group, Penn State, really across the country. And what they found out was that they questioned patients who took part in the process and wondered what was the driver for them to take the team up on the offer to meet with a pathologist. And really the bulk of it was a better understanding of my health condition. Something I've been stressing throughout here is really you need to become the best educated patient you can. And that seems to be the major driver. Number two here is recommended by my treating physician. And that's something that definitely happens here. Our oncologists have highly recommended the opportunity to patients. So a chunk of the patients that come through have definitely been referred by the oncologist team. Other help me make decisions about treatment, lessen my anxiety. I feel as though breast cancer, it's sometimes a shapeless, vague entity, and really to see it under the microscope gives a patient a concrete example of what it is they're battling, and that may psychologically help a lot of patients. The key points that came out of that paper was that it was that the participants thought pathologists communicated respectfully, empathetically, and that they would highly recommend the program to other patients. It improved their understanding of their health conditions and satisfaction of their overall healthcare experience. It really was a positive driver to the entire experience. One final paper I want to look at, this one came out shortly after our paper, was what happened here, and it looked at, again, patients who took part in this process. And in a select group of cancer patients, there's very high level of interest in a patient pathologist consultation program. That's something I started off with. It's not for everybody. If the patient is definitely interested, I know I personally love to show them their pathology. Pathologists, clinicians, and hospital leadership should work together to pilot these programs in diverse settings. And I think this is just getting started at a lot of places across the country. Additional quantitative work to scale interventions for interested population, to design effective patient-centered consultation programs, and to assess value are truly needed. There's some great quotes that were captured in that paper that I want to really talk about, and it goes to the sort of why to meet your pathologist. And we've touched about on empowerment, demystification, demystifying the process of diagnosis, seeing what actually goes into the diagnosis. For what I illustrated, what goes into getting that tissue from your body to the slide, and enhanced understanding of that pathology report. There's some great quotes here. Knowledge is power. Analysis and increased understanding of the diagnosis empowers patients, reduces anxiety. Having knowledge helps me focus and stay calm. I've always found the world of pathology mysterious, would love to see what they do, especially with my own tissue. This is something usually kept behind the scenes. It would be interesting to see. There's definitely a lot of interest in the pathology community about being more forward-facing and wanting to meet with patients and letting patients know about how we play a part in their care. I still don't know what all the wording in my path says. It would be nice to be able to have somebody explain it. That's a very common theme that I have heard before, because I have several questions about the staging that resulted from my biopsy. Remember, the pathology report is what bases treatment and outcomes on, and it sets up the stage. There should be a stage reported in the report, and we can go through why a stage is a particular stage and what makes it different from other stages. I would have liked to have discussed my pathology report with a pathologist, because when I asked my surgeon, he said that he didn't know. There's different grading of tumor. I want to understand what is happening in my body. I want to understand all I can about my cancer. That's a great quote there. I wanted to wrap up here in going back to Candio Terry's story that we started the talk off. And I think this is another concept of the whole breast cancer saga, is there's a lot of waiting, and understanding what goes into putting together a pathology report, studying those slides, I think allays some anxiety in patients, knowing why it takes some time to put all of these elements together in a pathology report. And I think this is a great quote here, and it highlights that pathology plays a role throughout the care of the patient, not just from first diagnosis, but also a subsequent excision, mastectomy, and even further therapy down the road. If there's a biopsy in the future, we may pull something out and look to see how it compares with the original cancer. One of the most difficult parts of a breast cancer diagnosis for me was the waiting game, from the abnormal mammography results to the ultrasound, biopsy, surgery, and pathology tests. Fear filled my head. My life was suspended in time. I call this anxiety the worry wheel. Round and round it goes, showing me images of all things that could go wrong. I did my best to rest and recover following the lumpectomy, but I was hyper-focused on the results of the pathology. On the day after Christmas, we received the greatest gift of all: clean margins outside the tumor and no cancer in any of the lymph nodes. And for me, that's a really concrete example of my diagnosis meaning something to a person and the family and the consequences of that. And to be able to share that knowledge with that person firsthand is great. It gives me a lot of pleasure in the work I do, and it's something that I enjoy doing. And this is really a quote that resonated for me specifically, and I'm sure others have have felt the same way, but being able to see that on a path report and understand what clean margins mean. You may want to ask, well, I looked at it with the pathologist and I see 2 millimeters or 3 or 4. So just knowing, armed with the background information, helps you make informed decisions and appreciate final decisions as well too, knowing that you made the right decision with everything you could learn possible. I'd like to finish up with that and turn it back over to Dr. Malkus. If she has any questions from the audience, we're happy to field those questions.
Thank you again for really an amazing webinar, so packed with information, and really this concept of including the pathologist as part of the care team. I think it's such an important factor. I want to invite our webinar attendees that if they do have any questions, they can use the drop-down menu on their GoToWebinar screen, which will appear on the side of your webinar viewing screen, and there is a drop-down menu for questions. Type in your question and hit enter, and I will see that. In the meantime, though, Dr. Misialek, I have a question. You know, given my role with MBCC and my own experience, I often have friends or friends of friends who get referred to talk with Barbara about their recent diagnosis. And now, as part of that, you know, conversation, I would love to also be able to recommend that they consider having a consultation with their pathologist. What should I recommend, though? How should they be going about doing that, especially if they may be working in an area of the state where they don't have a program in place for consultation practices?
That's a great question. I think the first step would be to reach out to whoever ordered the test. If it's a biopsy, for instance, the needle biopsy, there would be a primary care or even a breast oncologist who may already be involved at that point. And those would be the best ones to touch base with to see if the opportunity is available. You bring up a great point about more resource poor areas or areas geographically distant from where a program such as that might exist, not just in Massachusetts, but elsewhere in the country. There's people from outside Mass who are watching. It's interesting because right now some of my colleagues here at Mass General Brigham have applied for a grant to look specifically at that question, to offer this program to those in underserved areas who may not have access to a pathologist nearby. And that's something we're studying right now. So that's a hot question, and definitely maybe next year I'll be able to come back and share some positive movement where we have made progress in that area, but it's definitely being looked at right at this time.
And I just as a thought to what you were just saying, the potential opportunity for remote consultation. You know, one of the things we actually learned out of the pandemic that we can do is utilize technology as a means of providing access. So very interesting. We did get a question about making an appointment with the pathologist, and is there a need to be concerned about insurance coverage? Is there any type of fee associated for the consultation?
Right now, the program here that we offer at Newton-Wellesley is free of charge. We don't charge for it, we don't bill for it. It's not an onerous time obligation for the pathologist, simply because the interest level is not super high yet. It would be a good problem to have, to be very busy and not have time to see everyone. Would love for more people to come in. Right now, we don't charge for it. As I mentioned, Some of my colleagues who are just starting the program at other institutions do create a report that goes into the medical record, and they do bill for it. My experience has been that from what I hear, that patients are not charged anything on that.
And so once I get the appointment, I have that opportunity. What are the things that I should be asking? If I'm really concerned about, I want to become more informed regarding my own health care, what are those questions I should kind of have prepared so that I know I'm getting the answers I need?
I think bringing in the copy of your pathology report and just having the pathologist go through line by line what each word means, why is that important? We include those in the report for a reason, and I highlighted some of those important prognostic factors in the talk about estrogen, progesterone, HER2, margins, lymphovascular invasion. I think making sure you understand those issues is important, as well as just the basic about what I refer to as the grade of the tumor. Is this a tumor that is grade is analogous to differentiation, meaning how closely is that tumor trying to recapitulate the tissue that it came from? How well is it trying to make normal ducts? And that tendency often is linked to the biology of the tumor, meaning those that are more poorly differentiated generally have a more aggressive biology. And I think understanding that concept is important for patients, and asking the pathologist, where do you feel my tumor fits into that bucket of behaviors? And that could be one of the greatest experiences I think the patient might learn.
And so, you know, for me, I felt like suddenly I was thrust into this world that was relatively new to me, in terms of understanding all of the various aspects of care. And there was a lot of decision making, particularly around course of treatment. And so, you know, is the pathologist really able to, as you said it at one point, share in the decision making of the course of treatment and provide that guidance to the patient?
That's a great question, and sometimes we do get asked questions about treatment, and I'll make it a point that we're not going to offer opinions on treatment, different forms of treatment, or what we personally think. We leave that to your other care team members, the oncologist, surgeon, radiation oncologists, about what types of therapy are on the table as far as chemotherapy, radiation, and surgery. We're not going to push one way or the other. We feel that knowing as much as you can about the tumor will help you make a decision that's right for you and your tumor, with input from your other care team members.
And speaking to this differentiation of consultation, right? It's patient pathology consultation, and the concept of shared decision making. Where is the role of the pathologist as part of the patient care team in working with the other experts to be able to really make those recommendations for course of treatment?
Generally, at most institutions, there's a weekly meeting or bi-weekly meeting of your care team members. Quote, Tumor Board has evolved to the point now that it's a more specific conference. That's, for instance, we just have a conference for breast cancer, and the new patients who are diagnosed get presented, and all of us talk about that particular patient's tumor. and recommendations are made from other members around the table about what's the most appropriate next steps for that patient. And that all is based on knowing the pathology, knowing the radiology and the results of that. So I would say that the pathologist is very similar to a radiologist in that we're providing the information that goes into the decision-making process for other team members about the best course of therapy.
And we have a really interesting question here. Is tumor grading different for different types of cancers? Is there similarity? What types of similarity for different types of cancers? Is there a similarity? What kinds of similarity are there for tumor grading?
Tumor grading, as I mentioned, basically deals with the fundamental concept of how well does that tumor try and create tissue from which it arose. So for instance, breast, is it forming breast ducts or not? A colon cancer, is it forming colon glands or not? And that goes for any cancer, any type of what we call an adenocarcinoma, a gland forming cancer. How well is it trying to form glands that look similar to the organ from which it arose? And if they're nice uniform glands, back in some of those images I showed you, nice round like donut looking tumor glands, that would be something that we'd consider well differentiated, and that would be regardless of tumor type, whether it's a lung, a colon, a breast, ovary. Well differentiated is one that looks very orderly. It's trying to mimic the organ that it came from. It may not look very, quote, ugly. At the other end of the spectrum are tumors that sometimes we have trouble deciding even where they came from because they really don't give us clues of the organ that it arose from. And that's when we have to resort to some of those stains like I showed you earlier to sort things out. Those would be at the other end of the spectrum or poorly differentiated. And as is the case with any spectrum, there's always something in the middle that we call moderately differentiated. So all cancers really do try to get broken down into one of those three grades. Is it well differentiated, moderate, or poorly differentiated?
Wow. I want to say again how much I appreciate all of the information that you bring. And really, I really feel like this is such an important topic for understanding both diagnosis and then ultimately treatment. So thank you again for this really amazing presentation.
Thank you.
On behalf of myself, the MBCC board, and Cheryl Osimo, MBCC's executive director, I want to thank Dr. Misialek for this very informative discussion today. And I want to thank all of our many listeners for joining us. For those interested, the recording of this webinar will be made available later today on the MBCC website at mbcc.org. If you would like to further support our mission of preventing environmental causes of breast cancer, please consider making a donation by visiting mbcc.org/donate. I appreciate your consideration. Have a good afternoon. Thank you again, Dr. Misialek.
Thank you very much.